Good afternoon, and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Today, we'll be having a Q&A on recent regulation updates, plus other topics related to long-term care facilities. We will open with pre-submitted questions and frequently asked questions. If you have a question for our panel, you can submit it using the chat tool or the Q&A tool in your Zoom menu. And if you would like to ask a question out loud, you can also use the tool to raise your hand to request to be unmuted. And now I'd like to briefly introduce today's panelists. We have several of our quality improvement specialists here today. We have Deborah Wright, Penny Imes, Shirley Sullivan, and Christopher Henry. We're also joined by our infection preventionist, Jennifer Brown, and Quality Insights Medical Director, Dr. Jean Storm. And before we get started on this week's questions, Deborah Wright is going to talk briefly about QSEP and the Centers for Medicare and Medicaid Services training modules.
All right, thanks, Kathy. So we just wanted to take a moment because we know that a lot of us have been talking over the last couple months, it seems like the last year, about the CMS training modules for targeted COVID-19 training for frontline staff and management staff. And we know that a lot of you said, some of those modules were outdated, and we just wanted to draw to your attention that at the end of May, those modules have been updated, and they are they're actually really good, and they have made those updates in a number of the modules to where we are right now with treating and working with COVID. So even if you're not a facility that is having all of your staff go through those modules, it may be something good to have your infection control or staff development nurse watch those modules so that you can incorporate that into your infection control and COVID related training. So we'll have more on that in the future, especially if you're a facility that is utilizing the QSEP modules for those trainings so that we can help you work through that. And certainly if you have any questions, you can always reach out to any of us and we'll be happy to help you with that.
Okay, thank you, Deb. So our first question that we had submitted in advance, what is the new definition of up-to-date for COVID vaccinations?
Sure. So everyone that's aged 6 years and older at this point is eligible for the bivalent Pfizer or Moderna COVID vaccine. Also, anyone over age 65 years of older may get a second dose of the bivalent Pfizer or Moderna, but that's not necessary to be considered up to date per the definition. And that's something for that second bivalent booster, you would want to talk to your physician or the resident's primary care provider.
Our next question is, can you explain why the NHSN definition of being up to date on COVID vaccines is different than this new definition being used by the CDC and state health departments?
Sure. So unfortunately, the timing of all this is not in your benefit. So as we know, NHSN reporting, they change their reporting guidelines on a quarterly basis. So since CDC changed the definition of up to date early in the NHSN's quarter, unfortunately, we need to wait until June 25th for NHSN to catch up with that new definition. So technically, you could have someone that is up to date in your facility per the new CDC definition, but in NHSN, unfortunately, you're not going to be able to capture that because you still have to look at their primary series first. So with NHSN, you have to answer the question, have they had their primary? If they've had their primary, then you go down through the additional boosters, and from that, are they up to date? So it is very confusing at this point. We have another month and a half to deal with those two different definitions. And certainly if anyone has any particular questions, we can look through specific situations then.
Okay, great.
I also wanted to say Kathy, I'm sorry, that NHSN does have training scheduled for those changes in HSN. They've posted them, and they're at the beginning of June. So if you haven't signed up for those already, look at your NHSN emails and make sure that you get signed up for one of those trainings.
Great, thank you. Our next question is, how long are nursing homes going to be required to offer residents and staff the COVID vaccine, as well as educate them on the vaccine?
I'll take that question, thanks. So far, unless there's any other further kind of regulatory action, excuse me, the end date of the to stop offering vaccines to staff and residents is May 21st of 2024. But of course, the best defense for that is to keep people up to date with the bivalent vaccines.
And are nursing homes still required to check temperatures or screen people as they're entering the building?
The required pre-screening, is no longer required. Instead, signage is to be posted at all the doors. They recommend in dining rooms and major areas where everybody congregates, and they do suggest a date on those so that they know it's the most up-to-date information. But all people entering should have a sign that says if they've tested positive or had close contact with someone within the last 10 days that has been positive, or if they're having any symptoms, that they should not be entering the building. And if a resident is out more than 24 hours, you need to do your facility screening policy as they are a new admission. With all that being said, it's important to review your screening of visitors and new admissions policy to make sure you're up to date with what it is that you're actually following. If your policy is more stringent than the current guidance, then you will be held to what your policy says.
Thanks. We just got a follow-up question in the chat. I think that either it was answered or it's going to be addressed soon. Let's see. It says, do we still have to screen residents? And yes, that's going to be one of our questions here that we'll cover here in a moment.
Okay.
Thank you. So next, these are some of these were pre-submitted questions, so we're just running through these real quickly. We have a couple questions about enhanced barrier precautions. If a resident has a skin tear but is not known to be colonized by an MDRO, should staff use enhanced barrier precautions while caring for the resident? And if not, what type of precautions should the staff use?
Sure, I can answer this question. So if a skin tear can be covered by a Band-Aid or a similar dressing, then the resident is not going to be required to have enhanced barrier precautions. Enhanced barrier precautions, or EBP, should be utilized if the resident has chronic wounds, so a pressure ulcer, a diabetic foot ulcer, an unhealed surgical wound, or chronic venous stasis ulcers. So with every resident, we want to make sure that we are stressing standard precautions utilized during resident care. Standard precautions should be utilized unless enhanced barrier precautions or other precautions are going to apply. For this resident, we would not be using enhanced barrier precautions.
And another enhanced barrier precaution question, it says, if staff is using enhanced barrier precautions or contact precautions during resident care, should linens, gowns, and gloves be treated as biohazards?
So we've been getting I've been getting a lot of questions about what constitutes a biohazard, and should those gowns and gloves and linens, if we're utilizing enhanced barrier precautions for a resident, if those gowns and gloves and linens should be treated as a biohazard. So you should always refer to your local and state regulations regarding disposal of medical waste. You can never go wrong when you do that. But according to the CDC, unless the garbage and linen contains regulated waste, so that's what they use that term, regulated waste, and it's defined by OSHA as containing a semi-liquid or liquid blood or other potentially infectious materials. They define that as OPIM. So these are contaminated items that would release blood or an infectious material in a liquid or a semi-liquid state if compressed, items that are caked with dried blood or in infectious material and are capable of releasing these materials during handling, any contaminated sharps, obviously, any pathological and microbiological waste containing blood or a potentially infectious material. If the linen or gown contains any regulated waste as defined by OSHA, then the waste should be disposed of as a biohazard and treated as such. So if the linen or gown or anything that you're going to throw away does not have any regulated waste on it, then it just can be disposed of in the residence room in a container. But otherwise, it should be treated as a biohazard. And you can look at the definition of regulated waste on the CDC site. OSHA also has a really good definition. If you want to, if you're not sure, you can take a look at the OSHA website. Otherwise, typically, if you're not going to have a medical waste that is contaminated as with regulated waste, then you can just dispose of it as such. And it doesn't matter if we're doing contact precautions or standard precautions or enhanced barrier precautions. If we have regulated waste on whatever we're throwing away, then it needs to be treated as a biohazard.
Okay, thank you. Next question. Now that the public health emergency has ended, can the FDA's emergency use authorizations or EUAs continue?
Yes, I'll take that. So yes, the FDA's emergency use authorizations for COVID-19 products like tests and vaccines and treatments will not be affected with the ending of the public health emergency. And the FDA's ability to authorize new EUAs also moving forward is not affected.
Thank you, Shirley.
Mm-hmm.
Next question. Can the Janssen COVID-19 vaccine still be given?
And the answer to that is no. The J&J vaccine should no longer be used. The FDA did remove guidance for the use of that, and the government stock actually expired on May 7th. So moving forward, all stocks should be disposed of, and the J&J can no longer be used in the United States. And just as a reminder, to be up to date, if you did have the J&J, you have to get either the Moderna or Pfizer mRNA vaccine 2 months after the J&J vaccine.
Thank you.
Mm-hmm.
So our next question is circling back to the one that we found in the chat earlier. Is it still required to screen residents daily for COVID-19 symptoms?
So while earlier versions of the interim infection prevention and control recommendations for healthcare settings did recommend that, residents be actively monitored upon admission at least once a day for fever and symptoms, that guidance is no longer in place. We had a question about that last week, and I wanted to make sure we answered that. However, some facilities may have that language still in your COVID-19 medication plan and your policies. So just double check your policies if you're going to change that recommendation, and make sure that your current policy reflects the practice that you're doing.
Thank you. So one nursing home asked, could you discuss the CMS memo related to CLIA, QSO 2315 CLIA? There is a section about point of care antigen test. They wrote, my interpretation is the POC antigen tests cannot be used on asymptomatic individuals, as this alters its IFU. Does that mean we can't use the rapid test on an asymptomatic person who was exposed to COVID?
Okay, so about the QSO. So on May 11th, a document called QSO 2315 CLIA was released, and it discussed how laboratories should handle testing considerations after the pandemic ends. So during the pandemic, certain CLIA regulations were not enforced by CMS. as long as specific guidelines were followed. Policies and procedures were also relaxed or changed to, make it more flexible within the CLIO regulations. However, with the end of the pandemic, some of these relaxed policies have been terminated. And although a lot of the memo talks about larger labs that perform high complexity laboratory testing, there are some highlights that might be helpful for the long-term care setting. And one change is that reporting of these SARS-CoV-2 test results under CLIA regulations are no longer required. However, there may be reporting requirements at the state or local level. Additionally, the end of the pandemic does not mean that the antigen tests cannot be used on asymptomatic individuals. The FDA has authorized numerous antigen and molecular tests, as well as over-the-counter tests that were intended to use for asymptomatic individuals. So the facilities must follow the manufacturer's instructions for use, or the IFU, including the intended use for COVID as well under the CLIA regulations. And I'm going to drop a link in the chat so you can check what tests you have and see if it's still authorized, and you can download a copy of the IFU to check to see if asymptomatic individuals can be tested with that test.
Thank you, Jen. Our next question, can nursing homes use the amount of admissions with COVID in a local hospital for a metric to replace the transmission levels?
Yeah, I know we had talked about this a little bit on our call last week with, those county transmission level rates going away. And Kathy, do you have that CDC link?
Yes, I do.
If you want to throw that, Kathy will put that into the chat. There is a CDC webpage now that gives the interim guidance for moving forward with the PHE ending and, how to address COVID. It's a great website. There are community COVID-19 community levels, hospital levels that are tracked. And the website that she put up will take you to that tracker. And that might actually, looking at those COVID-19 community levels that tracks by county. So that might actually give you a better picture. And I actually went on to the website, pulled up some surrounding counties just to try it out and see what it's like. And it's very nice. And it gives you, that hospital transmission level. So that will probably be one thing that would really help nursing homes know, where their levels might be and whether they're high, low, whatever. And then that whole web page is really good for some interim guidance and some requirements and things that you want to read through and maybe put into place.
Thank you. And this is the last of our pre-submitted questions. So if anyone has a question that they'd like to have us clarify that we've discussed today, or any other question related to long-term care, this is a good time to go ahead and submit that to us using the chat, the Q&A tool, or you can also raise your hand to ask your question out loud. So this is our last question. And it says, is there a PA-HON, which is Pennsylvania Health Alert Network memo, to cover infection control questions for the PHE ending?
Yeah, and this also came up. We talked about this last week. Somebody said, do we have our PA-HON yet? And I said, they usually will gather all the information, put it out there, and lo and behold, on 5/11, PA-HON 64. Was it 60? I got to look at my writing. 694. Sorry about that. Can't read my own writing. It was released. And again, that actually the PA-HON has that link to that CD tracker that I was talking about, but it does give you the information to cover some of the infection control questions, really specifically for Pennsylvania. There's a description of implications for that CDC community transmission metric ending. There are some updated recommendations for your universal source control in your admission testing. And then they have a nice appendix in there that they added to assist facilities to implement that broader use of source control. So PA HON 694, release 511, definitely want to make sure that you have that, and that will help you to update, really look at updating your policies and procedures with that.
All right, thank you, Penny. And it looks like there's no questions in the chat so far, so I'm going to go over a couple closing items, so it's not too late. So if you have a question, you can submit them in the chat or the Q&A tool, or raising your hand if you would like to ask your question out loud. So again, I'd like to invite everyone here to join us for more of these webinars in this series. We hold them every Wednesday at 2 p.m. We also invite you to bring your questions to our virtual live chats every Tuesday and Thursday at noon. Deborah Wright will be there to answer your questions on topics like quality improvement initiatives, infection control, or MDS coding. You can find the links to the live chats and our webinars in the newsletter that we send out every Friday called the Last Minute Lowdown. And if you would like to receive that newsletter but don't think you're on the mailing list, you can email me at ccaudell@qualityinsights.org, and I'll get you on the list. And I'll drop my email in the chat right now. And if you'd like to contact any of our panelists here, just let us know, and I can get you their contact information. Looks like we have a question here. It says, is it still recommended that unvaccinated or not up-to-date staff and residents use source control even if universal masking is not in effect?
I can take that one. So while there's no official recommendation that they have to wear a mask, there's no differentiation between unvaccinated or vaccinated staff with regards to source control. However, there is a recommendation that you have something to sort of keep track of your unvaccinated staff. So that could be masking, that could be, whatever you choose in your policy to, it could be a self-screening or a screening at, the start of the day, whatever the case may be, but there has to be something to, keep track of those unvaccinated staff and their symptoms, even if the levels are low. But there's no mandate for masks. It's not any different for vaccinated or unvaccinated.
All right, thank you, Jennifer. And that's all the question we have so far. So I'll take a moment if the panelists here have anything else they wanted to add. Now would be a good time.
I think I'll just expand upon Jennifer's discussion regarding screening residents for COVID-19. So even though it's not required to do that screening, we are seeing a high number of facilities being cited for not testing residents that display symptoms. So if you're seeing a change in residents' condition and you are doing your assessment and you're documenting symptoms that you maybe would have been identifying with your COVID screening, you want to make sure that you're still testing them and screening them for COVID and following precautions until you have that test back. Some of those tests are resulting in negative, some are resulting in positive. It's not a problem till it's a problem. So just make sure that if your residents are displaying symptoms and you're doing that assessment, that you're following through with testing them for COVID or screening them for COVID as well.
And thanks for pointing that out, Deb. I wanted to add too, we might expect to see a few more of the F880 and 887 tags, maybe some deficiencies. So it's really important to continue to look at, that's kind of along those lines too, of even answering that question, like with the source control. I mean, it's going back to, let's continue to use our common sense infection control practices. If somebody seems to have something going on, then think about some kind of source control. So if somebody has cold symptoms, whether it's a resident, staff, visitor, just that basic infection control. Because I know looking at your infection control programs what you have in place, your policies and procedures, that is something that is going to be looked at over the next year closely. So you want to make sure that you have all that in place.
Thank you, Penny. So we just got another question in the Q&A. They ask, we do ask if new hires are vaccinated. However, we are not asking anyone to test unless they are symptomatic. I'm keeping track of unvaccinated employees in an Excel spreadsheet. Should we be testing unvaccinated employees? I only read that is facility decision based on COVID rates.
Yeah, that's correct. You know, unvaccinated, whether they're unvaccinated or not, routine testing is not recommended. But of course, you know, as Penny and Deb mentioned, if anybody's showing symptoms, you should, you know, follow the proper protocols. But routine testing is not a recommendation at this time.
Thank you for your question. And the person in the Q&A said thank you too. And I think that's it for questions for today. So I think I can wrap us up. Before we sign off, I'd like to ask everyone here to answer a short evaluation for today's short evaluation of today's webinar. The evaluation is anonymous and will show as a pop-up as soon as the webinar ends. So if you have a couple minutes to fill that out, we would appreciate it. I'd like to thank all of our panelists for joining us today. And I'd like to thank all of you for joining us today and hope you can come back and join us again next week.